The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast.
Hello, everyone, and welcome to the Washington Manual of Surgery podcast. We bring you everything you need to know about high-yield general surgery topics built for your just-in-time learning. On this episode, we're thrilled to have Dr. Mutch here to review the management of all things anorectal. Dr. Mutch is a colorectal surgeon at Washington University in St. Louis and the head of the colon and rectal section. He's also a previous president of the American Society of Colon and Rectal Surgeons. My name is Ahmed Eltahir, and I'm a general surgery resident at WashU, and will be your host for this episode.
Thanks, Ahmed. Happy to be here.
So today we're going to be talking about anorectal diseases, a topic that affects many of our patients, but is usually not focused on enough by general surgery residents. We're going to review a variety of benign and malignant conditions, focusing on both diagnosis and management. So to start things off, the anatomy of the anal canal can be confusing. So before we jump in, let's review some high-yield anatomy. Dr. Mutch, can you tell us about the anatomy of the anal canal?
So the anal canal is sort of that transition from columnar epithelium of the GI tract to the squamous skin of the outer sort of world, so to speak. And there's a columnar sort of transition in there. In the structures around the anal canal, you have the internal sphincter as the sort of circular muscular wall passes through the anal canal. And then you have the striated voluntary muscle of the internal sphincter or the external sphincter, as well as then the levators that make up the pelvic floor.
So now that we covered some anatomy, let's move on to one of the most common benign conditions, hemorrhoids. So you're in clinic and your next patient is a 29-year-old male who's complaining of intermittent bleeding with no pain. How do you evaluate this patient and what are you thinking about in your differential?
Well, I think everybody comes in to our office with a complaint of hemorrhoids. That's sort of the generic layman's term for problems of the anus and distal rectum. And so your history becomes very important because you need to sort out, is this truly hemorrhoids? Is this a fissure? Is this abscess? Is this a cancer, a mass, proctitis, all of those different things. And so your history becomes very important, and you should ideally be able to narrow things down in a couple of questions. A, what is the character of the bleeding? Bright red, associated with bowel movements. Is it on the tissue? Does it drop on the bowl into the toilet bowl? Is it streaked on the stool? If there's pain, generally hemorrhoidal disease is, at least internal hemorrhoidal disease, is painless bleeding. So if you have pain, then you need to start thinking of other things.
And you kind of referred to this very briefly. Can you tell us a little bit about hemorrhoid grades?
So hemorrhoid and how you sort of ultimately treat them and think about them is really based on symptoms. So the two things that internal hemorrhoids do, they typically will bleed and prolapse. So your grading system is based on those two sort of symptoms. So if they bleed alone, that's grade 1. If they bleed and prolapse but then reduce spontaneously, that's grade 2. If they bleed, prolapse but require manual reduction, that's grade 3 hemorrhoids. If they bleed or prolapse but do not reduce, that's then grade 4 hemorrhoids.
So now that you've identified it's a hemorrhoid, figured out what symptoms are affecting the patients, what treatment options do you have available?
The first line treatment for all hemorrhoidal disease should be just a high fiber diet, get plenty of water. So you want 25 to 30 grams of fiber in your diet a day. You want 8-ounce glasses of water in your diet a day. Minimize your pushing and straining, your time on the toilet. Sort of get in, get out, don't sort of linger. That should deal with most symptoms of grade 1, even sort of grade 2 hemorrhoids. If they, a good trial and compliance with fiber, and it will take several weeks for that to even sort of be able to know if you're making any progress. So you'll typically see them back in 8 weeks or so. If they're still having symptoms, then you have office-based therapies available, whether it's infrared coagulation, which are good for grade 1 hemorrhoids. You can then do rubber band ligation, which are good for grade 1 and grade 2, sometimes grade 3. But if they even fail treatment at that point in time and they're symptomatic enough, then you can talk about operative management. Operative management includes hemorrhoid ligation or hemorrhoid artery ligation or THD, and then an excisional hemorrhoidectomy. All of those are sort of escalation in pain in your postoperative recovery. So, typically you never really want to talk a patient into surgical management. They have to be sort of willing and their symptoms bother them enough to say that that's worth the price.
So I think as we discussed, even when it comes to the office-based therapies, you have a lot of options, and ultimately it really will depend on patient symptoms and surgeon's preference.
Correct.
So let's move away from hemorrhoids and go on to anal fissures. So you have a patient in clinic complaining of severe pain every time he defecates. How do you approach this patient?
So this sort of falls into the sorting out what's going on. And if it's, causes of severe anal pain typically are going to be an anal fissure, abscess, or a thrombosed external hemorrhoid. So basic inspection and it will help sort of sort that out. But also with history is generally it's associated with bowel movements. They may complain more of an itching or an irritation. It may last for a couple of minutes, but it may last sort of all day. Everybody's a little bit different. But on inspection, you just want to sort of spread the cheeks apart and see if you can see a fissure. If somebody has an acute anal fissure, you don't want to do a digital exam because that's incredibly painful. So we'll take a Q-tip or a cotton swab and just swab the anal canal to see if you can reproduce their pain. Generally, these are going to be in the posterior and anterior midline. And so if you reproduce the pain and it's severe and the same character that they are, then that's pretty diagnostic for an anal fissure. Oftentimes you'll be able to see it. So at which time you'll start once again with a good high fiber diet, get plenty of water, and then you'll add a topical smooth muscle relaxer, whether that's calcium channel blocker or nitroglycerin.
And so kind of continue on with treatment, whenever I think of it, similar to hemorrhoids, there's a list of escalating treatments. So you started talking about some of those treatments. If those don't work, what do you move on to after that?
Well, the reason that the underlying pathophysiology of a fissure is that you get a hypertonic or spastic internal sphincter muscle. And so all of the treatments are geared towards relaxing that internal sphincter. So the topical treatments will do it for sort of hours at a time. So you have to reapply it. The next step would be then Botox, which would paralyze the internal sphincter muscle for up to 3 months. Hopefully allowing the fissure to heal and then avoiding any further escalation. The most effective thing is a sphincterotomy, where you actually cut the internal sphincter muscle just only along the length of the fissure. But the big risk of that is, do you have any sort of alteration in continence? And so all of these things need to be discussed and advised with the patient.
And I think I just want to bring us back to a quick point, is that most of these are found in the posterior anterior midline. But I think it's important to remember when they are not and they're in the lateral regions, you have to think about other stuff and have to have a more comprehensive workup as well.
Correct.
All right. So let's shift gear to another high yield topic, abscesses and fistulas. So in order to understand this topic, I would highly recommend Googling some diagrams or referring to our Washington Manual of Surgery to understand the anatomical classifications of these abscesses and fistulas. Dr. Mutch, when you have a patient who's presenting with an acute anal abscess, what do you do?
Well, first you obviously examine them. You want to see if this is the first time they've had it. Have they had multiple abscesses? And then you want to identify where it is. Do you see an external component in the sort of anterior or posterior ischiorectal spaces? Is this a perianal abscess that's sort of right near the anal verge? Or is this then an intersphincteric abscess, which you don't see anything internally, but you can feel a bulge and bogginess on digital rectal exam?
So once you've identified roughly where it is, how do you treat these abscesses?
So what it really does is it depends upon sort of where the sort of fluctuance is. If it is in the ischiorectal space, then you would drain it externally. If it's in the intersphincteric plane and it's heading more cephalad, then you would drain that internally, because where you drain it will impact if you develop a fistula and how you ultimately manage that fistula.
So what's the main principle to keep in mind when you're draining these abscesses?
Radial incision and as close to the anal verge as possible.
So unfortunately, many of these abscesses, like you said, when they persist or reoccur, will present as fistulas. So what is your fistula management strategy?
In order to ultimately fix a fistula, you need to identify the internal opening. If you can't identify the internal opening, then it's difficult to ultimately treat a fistula. And it can either be very easy or it can be very difficult. And so then once you identify the internal opening, then it's a matter of how much sphincter is involved. If this is a simple intersphincteric fistula or a low transsphincteric fistula, then a primary fistulotomy is ideal. That destroys the internal opening, deals with the tract, and your recurrence rate is less. The more sphincter that's involved, then the more concern you have with a fistulotomy is that you will then create incontinence. So you want to preserve sphincter. So you have the lift procedure that's available, which is a ligation of internal fistula tract. You have an endorectal advancement flap, and you can also do cutting setons.
And is there anything that you use to help you figure out which treatment strategy you're going to employ?
Editorially, these are probably some of the most difficult things that we deal with because they can be very challenging. Success rate of lifts and endorectal advancement flaps are in the 60 to 70% range, so none of this is great. All forms of treatment for fistulas does carry risk of alteration in continence. So even though you're preserving muscle, anytime you sort of disrupt the sphincter complex, you do have a risk of altering continence. So my preferred treatment is a cutting seton.
And lastly, anything to keep in mind when you're treating men versus women?
Well, I think you just have to be much more judicious in how you manage the sphincter muscle in women, because particularly if they've had children, their risk of continence is going to be significantly higher. Men typically tolerate a more extensive fistulotomy. You can divide probably up to 50% of your sphincter complex in a man and probably not have much change in continence. But in a woman, that's probably not as well tolerated.
So yeah, unfortunately, I think the treatment for these fistulas can be very frustrating for patients and surgeons alike. And at the end of the day, it really will depend on surgeon's preference and the exact anatomical location of these fistulas. So now that we've covered a variety of benign conditions, for our last topic, let's move away from them and discuss some malignant conditions, i.e. anal squamous cell carcinoma. So when you have a patient who's coming in with anal squamous cell carcinoma, what do you include in your workup?
Well, I think the first thing is, once again, is a history, because oftentimes these will masquerade as other benign anorectal entities. They'll bleed, they'll have pain. But typically you can tell that they're different because usually it's a more constant pain that does or doesn't get better with defecation. And then physical examination. Is this on the anal verge, meaning out onto the skin, which you can then treat as long as it doesn't involve the sphincter complex and is typically less than 2 centimeters, then you can treat that with just wide local excision. But if it involves the sphincter complex or extends up into the rectum, then obviously local excision is not practical. And so that's where we then would start thinking of chemo-radiation for therapy. Staging involves just a typical cancer staging workup. You can start with a CT scan of the chest, abdomen, pelvis. A PET scan is definitely much more useful in patients with anal cancer because it allows you to follow the response. So if patients become PET negative after chemoradiation, that's probably the best prognostic information that we have as far as what their at least risks of local recurrence are.
And you've already referred to it, but can you tell us a little bit about the chemoradiation treatment of these cancers and the kind of surveillance or follow-up afterward?
So typically it's sort of what has been known as the Nigro regimen. There are certain modifications to it, particularly on the chemotherapy side. Can be anything from 5-FU and mitomycin to other sort of chemotherapy agents. Typically, the radiation therapy is 25 to sort of 30 treatments often depending upon what the PET scans and whether there's concern for inguinal adenopathy or mesorectal or lateral pelvic adenopathy, they can expand the radiation field. Then you will see them about a month after they are done to assess their response. Ideally, the tumor has gone away at that point in time, and they can just go on routine surveillance of every 3 months or so. However, if there is still some residual tumor, you will then continue to just monitor that and probably see them on a little bit shorter interval to ensure that the tumor continues to regress. You're not going to do anything, biopsy or treat or change your treatment for a minimum of 6 months after completion of chemo-radiation therapy because the radiation can continue to work at that point in time. However, if there is, during that short interval follow-up, there is progression or increase in the size of the tumor, then that would be a point where you would intervene and say, okay, this is not going to have a complete response, and then would proceed with surgery.
And in contrast to squamous cell carcinoma, how do you treat adenocarcinoma of the anus?
So adenocarcinoma of the anus is a much more aggressive tumor than even an adenocarcinoma of the rectum, but typically you treat them with the same regimen that you would for a adenocarcinoma of the rectum, which would be chemo-radiation therapy followed by sort of systemic chemotherapy, which would be more FOLFOX-based chemotherapy.
So there were some complicated topics to unpack, and even though we covered a lot, there are a few more topics we didn't cover, so I'd recommend referring to our Washington Manual of Surgery manual. Dr. Mutch, thank you very much for taking the time to talk with us today.
Thank you. My pleasure.
We are Drs. Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams and Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.